Okay, hello everyone, and thank you so much for checking out this short video session on the SCTS website. My name is Enoch Akowuah. I'm a cardiac surgeon in James Cook in Middlesbrough, and I'm joined by two colleagues today, Ralph White, also from Middlesbrough, and Reuben Jeganathan from Belfast. With the launch of the new SCTS website, we want to be able to share and discuss important events in cardiac and thoracic surgery with the whole surgical community in the UK. And this will include news items like groundbreaking research, which have an important impact on our patients and our profession. We're going to start this series off today by discussing an important trial which was presented at the ACC this weekend and published simultaneously in the New England Journal of Medicine. It's called the LAOS 3 trial. And perhaps, Ralph, we'll start with asking you to share some of the key findings from the trial to kick us off.
Okay, thank you, Enoch. I'll share some slides which are from the presentation itself. Okay, so the LAOS 3 study, which we participated in and contributed a good number of patients to, compared left atrial appendage occlusion at the time of concomitant cardiac surgery using one of three, there's actually four authorized techniques, which is either stapler occlusion of left atrial appendage, amputation and oversew of the left atrial appendage, device closure, which we use the AtriClip, or for those having minimally invasive mitral surgery, there was a double oversewing from the inside of the left atrium, with confirmation on TOE for all of these closure methods that the appendage was truly closed. Interestingly, all patients had a CHA2DS2-VASc score of more than 2. So interestingly, they all should have been on anticoagulation based on that guidance. And at discharge, around 80% were in both groups. And this tailed off a little bit to around 3/4 of patients by 3 years of follow-up. But it was the same for both groups. And then the interesting and important primary outcome was for ischemic stroke or systemic embolism, which was significantly lower in the left atrial appendage group. And it was more so after 30 days, suggesting that the incidence of stroke in the first 30 days is probably a consequence of surgery, and the incidence or the reduced incidence after 30 days is a result of the intervention. And there's a nice curve showing how the protection from systemic embolism or stroke actually improved over time. And then looking at the secondary outcomes and dividing stroke and embolism separately, death and hospitalization, heart failure, the big difference was ischemic stroke. So these are the conclusions which are in the paper which was published, which was that it reduces ischemic stroke by 33%. And after the first 30 days, by 42%, there was no evidence of any adverse effects. And this effect was a benefit which was additive to the oral anticoagulation, which was the same for both groups.
Thank you, Ralph, for that lovely summary. And so maybe, Reuben, I might ask you, what do you think the implications are for cardiac surgery in the UK in general of this trial?
Thanks, Enoch, and thanks for inviting me to this forum. I think there is huge implications. As we know, our cohort of patients are getting older, and as one gets older, the incidence of atrial fibrillation increases. And now with this recent data, which is a very well conducted study, and in addition with the anticoagulant, it does significantly reduces the risk of stroke. And one of our main issues with cardiac surgery is the risk of atrial fibrillation immediately post-op. And we're seeing more and more data come out. You see the partner tree data, you see recent guidance from the NICE guidelines. I think every effort should be taken now to try and reduce the risk of stroke in our cohort of patients.
Brilliant. So, Ralph, I guess we then focus on specific clinical situations. My own experience is in mini mitral surgery, and clearly we're going to have to work out good ways of clipping the appendage for that operation. But I'm thinking now particularly of patients who are increasingly being given the choice between TAVI and surgical AVR. If you had a patient in atrial fibrillation, will this trial affect the advice you give to that patient?
I think it has to, doesn't it? Because it's not just an equivalence or a slight effect, it's a massive reduction in the risk of thromboembolic complications. And it's added, I suppose, it adds to the pros side of the argument for open surgery versus and the cons for TAVI. When patients are weighing it up, they always weigh up because there are benefits to both procedures and there are complications or poor outcomes to both procedures when they're compared. So another thing that has to be mentioned to the patient is that we can do a surgical atrial appendage occlusion, which will reduce their stroke risk.
Okay. And Reuben, one of the things that we've been struggling with in terms of uptake in the UK has been ablation surgery for atrial fibrillation, concomitant ablation surgery. There's mixed and variety in terms of the number of patients who get ablation. Do you think this trial suggests that ablation is dead in the water and we should all just be clipping? And if we do that, we'll get most of the benefits that we wanted to get from ablation in the first place?
No, I don't think so. I think this trial shows the advantage of clipping from a stroke point of view, but the aim of the ablation, is to predominantly try and get them back in sinus rhythm with the subsequent benefits of the anticoagulation. But when a patient, especially in the mitral cohort of patients that we operate on, where they already have impairment in their LV function, and losing their atrial kick leads to another 20 to 30% reduction in their cardiac output. Getting those kind of patients with impaired LVs, there is a definite role of maybe considering doing a MACE procedure, or ablation. But I think one has to take into account of all the factors that will lead to a successful outcome from an ablation. So looking at the size of the left atrium, looking at the duration of the patient being in atrial fibrillation. And sometimes I know some of our Japanese colleagues, they look at the causality of the ECG, the P waves, the defibrillating waves, and how caused it is as a marker for successful ablation.
Thanks. And Ralph, just going back to the main LAOS trial, it was stopped early. Can you just tell us some of the reasons why that was, and whether if we'd carried on what we might have seen?
I think the reasons it was stopped early was because the results were very, as you've seen from the curves, were very clear. The curves were still diverging at cessation of the study. I think it's a shame it hasn't carried on a little bit longer, because you may see a much greater longer term benefit. Although if we all trust the curves, then we can all assume that's the case, but it would have been nice to have shown that. One thing the study didn't do was look at percutaneous closure devices, and that would be necessarily a second large study to see if that had the same effect as the surgical closure, which again then could be used in the TAVI versus SAVA discussions. And
then finally, does this trial now raise new research questions? Ralph, you've talked about percutaneous closure, but one thing that comes to mind is that, as you say, most of these patients were on anticoagulation. Is there any prospect of a trial with a clip and then stopping the anticoagulation? Or is there any prospect of a trial in clipping patients with no AF? I just wonder what you think about the future.
So the first one I think is relatively easy to answer. I think we know that anticoagulation reduces the risk of stroke by about 2/3, and the clip reduces it by a further third to 40%. So I'm not sure anybody would be particularly comfortable in stopping anticoagulation. It does give you some protection though, so patients as they get older who are required to stop anticoagulation for a short period for other interventions, I think that makes that safer, but not to stop anticoagulation completely. And then there's probably two studies. There's one study to see how many patients end up in AF as they get older with structural heart disease. And if it's a large number or a significant number, then clipping them at the time of their original surgery may give them some protection for something that they don't yet have.
Brilliant. And then Reuben, maybe just some final words about how you think this pivotal trial will change your own personal practice or the practice in the unit in which you work.
I think it has already. In fact, I've got a couple of text messages from my cardiology colleagues telling me about the trial, and coincidentally, we're doing this recording. And I must say, I think the biggest advocate for us, is our cardiology colleagues, because they look after the patients long term, and it's a total disaster. You get a good operation, 6 months down the line, they get a stroke from atrial fibrillation. So I think this, for me, I think has enlightened, has educated me. And I think, going forward, patients who, as Val described, charge thrust 2 or more and in atrial fibrillation, I would highly consider doing treating the atrial appendage, likely with a clip.
Brilliant. Great. Well, that's a nice note on which to end. It's a practice-changing study. Thank you, Ralph. Thank you, Reuben, for joining us for this short recording. For everyone else, please spend some time on the website. Please join the discussion forums, and hopefully we'll see you for our next production. Thank you.